Welcome to the Baptist HealthTalk Doc to Doc podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare. Join Baptist Health experts as they offer practical advice for clinicians covering a wide range of specialties. Cancer, neuroscience, orthopedics, and cardiovascular care are just some of the timely discussions you'll find right here on the Doc to Doc podcast.
Ladies and gentlemen, welcome to another Doctor podcast featuring the Miami Neuroscience Institute. And I'm your host for tonight's event. My name is Michael McDermott, and I'm here with Dr. Guilherme Dabous to discuss cerebral aneurysms. Dr. Dabous, thank you for volunteering your time for tonight's podcast.
Dr. McDermott, this is my pleasure. It's great to be here. Let's have a great conversation.
All right. So, as you know, I'm the senior-most member of the Miami Neuroscience Institute. I've been asked to help develop the department and the treatment of cerebral aneurysms and its evolution that we've seen over the last 40 years. In fact, I've actually asked one of our visiting lecturers to come and speak about the evolution of cerebrovascular surgery in the inaugural first Charles Drake Cerebrovascular Lectureship here at Miami Neuroscience Institute. First of all, could you tell the audience a little bit about the different types of aneurysms and their frequency in the population?
Of course. So when we're talking about intracranial aneurysms, they're basically two types of presentation. I think that's more important to focus really on the types of presentation of the intracranial aneurysms and a little bit on the different types of them. So when you have a brain aneurysm, basically you're going to be diagnosed with either an unruptured aneurysm, which basically a lot of times is an incidental finding. So the aneurysm was found because you're having an imaging study done for other reasons, such as maybe headaches or unrelated or dizziness or memory loss. And then you have the types that are really the most dangerous ones, which basically when the patient presents with what we call like a subarachnoid hemorrhage, which is when the aneurysm had bled. So, basically blood leaked out of the aneurysm into the brain or adjacent structures from the brain, and becomes like really like a medical emergency that needs to be fixed, usually like as an emergency. When you're talking about brain aneurysms in general, there's a slightly increased incidence in women compared to men. So this increased incidence persists when the aneurysm ruptures. So in subarachnoid hemorrhage, the incidence is also slightly higher in women. In general, when we're talking about the population, we're talking to patients about intracranial aneurysms, the overall prevalence, meaning like how many people are just walking around with an aneurysm that may know about it or not, is usually about 2 to 5% of the whole entire population carry a brain aneurysm. So you can see a lot of people are just walking around with aneurysms, and most of those aneurysms actually will never rupture. The problem is that we don't know which ones will rupture and the ones that will never rupture. So when we're seeing those patients, a lot of times it becomes a decision. We use some risk factors we're going to discuss further ahead. Now, when we're talking about the aneurysms that rupture, so the ones that really present with the catastrophic, what we call subarachnoid hemorrhage, when blood can leakage outside of the aneurysm, the incidence of those, it's somewhere between 6 to 12 per 100,000 people. So in other words, you see here, just doing a quick math, that most of the aneurysms will never rupture. Now, there's a very interesting data that is very recent in the literature. It seems that the number or the incidence of aneurysms that rupture is actually decreasing over the years. And this number was a little bit higher in the 80s, and now apparently it's a little bit lower, close to the 7 to every 100,000 patients. The reason for this, we really don't know for sure. It could be related to lifestyle changes, a lot of like less smoking, for example, and also to increased number of aneurysms that are found before they rupture that have been treated. So there are a lot of things that are very, very interesting. Now, of course, when the aneurysms are found incidentally, a lot of times they're not really causing any symptom. And when the aneurysm rupture, which is when, again, the blood leaked outside the aneurysm, a lot of times the patients present with what we call the worst headache of their life. So the patient is experiencing a headache that he has never felt before. Even patients with migraine, they know it's a different type of hemorrhage. Sometimes it can have associated other neurological symptoms, weakness, problems to speak, somnolence. And some patients, unfortunately, that have aneurysms that bleed will unfortunately not make it alive to the hospital. About like 15 to 20% of those patients, unfortunately, do have that. So as we discussed, the aneurysms are a serious condition, but thankfully, a lot of those aneurysms will actually never cause a problem. So it's really to the group treating the patient to really determine if that's an aneurysm that needs to be treated when it's an unruptured aneurysm, and when the aneurysm is ruptured, what is the best way to treat that aneurysm.
Okay, thank you. One of the developments that's been going on at a more basic level has been mathematical modeling of aneurysms and the hemodynamic flow patterns and stresses in the branching points of blood vessels that may be responsible for the development of saccular aneurysms. Has this research been helpful for you to counsel patients as to the risk of aneurysm rupture and making decisions about treatment or observation? And do you use special imaging studies that allow you to model the stresses, et cetera, in order to counsel patients?
Well, Michael, I think that's a very good question. There has been a lot of studies, recent studies that, using computational fluid dynamics, shear stress on aneurysm wall, that actually point out some interesting findings. For example, some branching aneurysm or aneurysms located in bifurcations have increased risk of rupture, potentially because the pressure on the aneurysm wall or the shear stress is increased. Now, a lot of those studies are not 100% clinically validated, and they're not available, in commercial scanners, for example. So a lot of times we require really research studies and specific protocols and software to really look into those type of calculations and imaging, right? So, but we use what we know, what we learn from those studies to really advise the patient about, for example, treatment of unruptured aneurysm. Now, considering that aneurysm that had already ruptured, needs to be treated. So this discussion is more relevant really to the patients that discover an aneurysm that is incidental. And we're going to discuss further ahead again. There's some other data that we use from many years of data and gathering studies and understanding what those data mean, really to advise the patient what's the best way to deal with their aneurysm.
So one of the questions that comes up relates to imaging as to whether or not CT angiography, MR angiography, for example, is as good as conventional catheter angiography for defining anatomy and assisting with decisions about treatment for different types of aneurysms. Could you comment on this for some of the patients that might be listening?
Absolutely. So the non-invasive neuroimaging, particularly speaking about CT angiography or MR angiography, which are basically the CT and MRs done specifically to look at the blood vessels in the patient's brain, had evolved tremendously over the last 10, 15 years, with the imaging capability becoming pretty good. I wouldn't say exactly the same as of a diagnostic, catheter angiography, which is the minimally invasive way to study the blood vessels in the brain. And why I'm saying that? Because there also has been significant advancements, and the procedure itself, the catheter-based angiography, also became much safer. We do 3D rotation. We can do actually what we call cone beam CTs with the catheter angiography, which actually has probably one of the best spatial resolutions that one can have. But no question that CT angiography and MR angiography are playing very important role when we're talking about intracranial aneurysms. Those are great screening methods. For example, if you're having headaches or if you have a history of aneurysm, that's a very good way to follow up aneurysm or to get a first study. Sometimes before you're really deciding if an aneurysm needs to be treated or not, a lot of times we end up still doing diagnostic cerebral angiography because, again, it's important to really understand the size of the vessel, really look into the aneurysm with some resolution that sometimes the CT angiography and the MR angiography cannot really give us. For example, if there are irregularities in the wall of the aneurysm, what's the size of the parent vessel, meaning the vessel where the aneurysm arises from, if there are branches close to the aneurysm or arising from the neck of the aneurysm that sometimes cannot be seen on the non-invasive tests such as the MR angiography or the CT angiography. So I would say that those tests a lot of times are complementary, but there's no question a lot of our patients are followed after treatments, for example, only with MRA or CTA, because they really don't require a lot of angiograms for follow-up because it's an invasive test and we want to avoid it as much as possible. However, all those tests still play an important role for the management of intracranial aneurysms.
Okay, thanks, Dr. DeBoos. Let's talk about treatment options now, and specifically in your specialty of endovascular therapy, and maybe just tell the audience how endovascular coiling is different than craniotomy for clipping of an aneurysm.
Of course. I think that's a very important point. So basically, historically, aneurysms have been treated with something that we call, craniotomy and microsurgical clipping of the aneurysm, where basically the neurosurgeon does a craniotomy, he opens the bone, he goes into the spaces of the brain, and he puts a clip that pretty much strangles the neck of the aneurysm and blocks completely the blood flow to the aneurysm using a titanium clip. Now, with the evolution of the devices and techniques, basically, endovascular start to become like a very important player on the treatment of intracranial aneurysms. Basically, endovascular means that the aneurysm is being treated through inside the blood vessel. So a lot of times what we put a catheter, which is this plastic tube that goes either through the groin or to the wrist of the patient, and we navigate, microcatheters to where the aneurysm, and we treat the aneurysm with like several different devices that we have available nowadays. Now, the first device really was a device that we call a coil, which is basically a platinum coil, which is inserted to these tiny tubes and basically blocks the flow that is going to the aneurysm. And this was initially developed in the early 90s, actually at UCLA, by an Italian neurosurgeon called Guido Guglielmi, and hence the name, detachable coil, Guglielmi detachable coil, its initial name, which was GDC. And this was actually approved by the FDA in 1995. So since 1995, we're treating the aneurysm through endovascular means, which is minimally invasive. It's less invasive than the open surgery, and that's its main advantage. Nowadays, throughout this last 20, 25, 30 years, there has been a lot of, advancements in the endovascular coils, in the devices. Now we have stents that we use to coil aneurysms. We have balloons that we use to do balloon remodeling, what we call. We have also like flow diverters, which is a special type of stent that is placed in the parent vessel or the artery where the aneurysm arises from, and kind of deviates the blood flow away from the aneurysm and basically cures those aneurysms, and it actually allows us to treat aneurysms that before were not really possible to treat. We have intrasaccular flow diverters, which basically it's a type of flow diverter that we place inside the aneurysm, and the advantage of that is that you don't need to put the patients on medications that thin their bloods, like antiplatelet agents. So the advancements of the endovascular field over the last 20, 25, 30 years have really, really been tremendous. And with that, really allows us to treat patients that sometimes even like 5, 10 years ago, we're not being treated, or we're not able to treat them. So that has been really, really marvelous for our patients.
Okay, very good. Thanks. So what about an unruptured aneurysm? What patient and aneurysm factors do you consider when making recommendations about treatment?
Yeah, Michael, I think this is probably the most important topic because, as I mentioned, a lot of the patients are walking around with aneurysms, and those aneurysms will probably never cause them a problem. The only issue is that we don't know the ones that will cause a problem or not. So we need to use the data that we have from the literature that basically will tell us which aneurysms, have a higher chance of rupturing compared to others. So, the most important thing here is actually the size of the aneurysm. Size and location, when it comes to the aneurysm, is the most important. So aneurysms that start to get bigger than 5, 6, 7 millimeters start to be concerning and increase the risk of rupture. The other thing is the location of the aneurysm. Some specific locations of the aneurysm inside the brain, or in locations in the blood vessels in the brain, have a higher chance of rupturing, such as aneurysms in the anterior communicating or posterior communicating regions. So those are the aneurysms that are more concerning, and we tend to be more aggressive with it. The other things is if the patient has family history of intracranial aneurysm, of most important family history of ruptured intracranial aneurysm, that makes it more, a higher risk of aneurysm rupture. So those aneurysms are usually treated more aggressively. The other thing is if the patient has problems with the blood vessels, some genetic conditions such as Ehlers-Danlos, for example, or polycystic kidney disease may increase the risk of aneurysms and aneurysm rupture. So that we tend to treat those patients more aggressively.
All right. So we've been talking primarily about unruptured aneurysms to this point, but ruptured aneurysms are a completely different situation and potentially life-threatening illness. So for our audience, just to let you know how potentially bad a ruptured aneurysm can be, many patients who experience a ruptured aneurysm will experience sudden death and never make it to hospital alive. Another 20% will die from rehemorrhage or complications during the hospital stay. 20% will get something called cerebral vasospasm, narrowing of blood vessels from irritation from the subarachnoid blood. And 20% will end up with something called hydrocephalus, obstruction of cerebral spinal fluid circulation or drainage requiring a shunt. So when you have a patient with a ruptured aneurysm, how quickly do you proceed with endovascular treatment following the admission of the patient to hospital with acute subarachnoid hemorrhage?
So when you're facing an aneurysm that ruptures, so the subarachnoid hemorrhage is already, in place, of course, the first thing that needs to be taken care of is the most urgent things, make sure the pressure inside the skull is relieved, right? So if the patient has what we call like hydrocephalus, is usually, there's a catheter that needs to be placed, and it's usually done by neurosurgery just to relieve the pressure inside the brain. And then the aneurysm is usually treated, or what we call secured, within the first 24 hours after the hemorrhage. That's the goal for us. So basically, if the patient comes in the middle of the night, he's probably going to be treated first thing in the morning. Sometimes, depending on the situation, or even earlier than that. But most of the time, that's with the aneurysm will be secure in the first 24 hours. Now, one of the things that's important too, a lot of these patients do have other risk factors for aneurysm rupture, such as hypertension and smoking. And that also plays a factor when you're talking about, the chances of those patients having a good outcome after the subarachnoid hemorrhage. But, again, with these patients should be secured, the aneurysm should be secured within the first 24 hours after the rupture.
Okay, good. So cerebral vasospasm, as we just discussed, is a phenomenon that occurs after release of blood into the subarachnoid space. And the risk of vasospasm is proportional to the amount of that subarachnoid blood. Now, we have grading scales for trying to determine this risk, but how do you treat vasospasm for a patient that arrives under your care? So
it's important to understand that vasospasm is very common on patients with subarachnoid hemorrhage. Actually, 70% of the patients will develop some angiographic finding of vasospasm, but only about 30% of those patients actually do require more aggressive types of treatment, including like interventional treatment. So the first thing that really we do if we're suspecting a patient is having vasospasm, there's something that can be done clinically. The patient is always taking nimodipine, which increases the chance of this patient having a good outcome, although it doesn't necessarily affect the blood vessels itself. But we have other things that we do. For example, we do induced hypertension, meaning we increase the blood pressure of the patient, we increase the fluids of the patient, and those things can increase or decrease the risk of this patient become like symptomatic from the vasospasm. Now, when they become symptomatic, then we do, again, a catheter-based procedure, and then there are a couple of things that can be done. We can inject some medication that basically relax the wall of the vessel, which are vasodilators, and basically the vessel dilates back to its normal size. And when the situation is really bad and sometimes the patients are not really responding to the vasodilators anymore, then we do what we call like angioplasty, which basically put a tiny catheter, again, all through the groin or through endovascular techniques, and we dilate this tiny balloons inside the blood vessel just to expand it. And that usually is a pretty good type of treatment for intracranial vasospasm, and usually resolves it, immediately.
All right. So can you tell us, Dr. DeBoos, about the team you have in place at Baptist Health South Florida for the care of and management of patients with cerebral aneurysms?
I think here at Baptist Health, we're lucky to have really a complete team, team of specialists to really can take care of unruptured as well as ruptured aneurysms. So we have interventionalists, we have cerebrovascular neurosurgeons, neurointensivists, rehab people to take care of after the patients, recover from all the acute phase and really are getting ready to be discharged, resume their life activities. I think we're really lucky to have all the disciplines really working together in pro to what's the best for the patient. So not necessarily only the interventional part or coiling, but also the neurosurgical part. Sometimes these patients are referred for surgery because the endovascular treatment may not be the best for them. So we really have the whole team here really ready to take care of the patients, really do what's the best for them, which to me is the most important thing, and really trying to provide them the best outcome possible.
All right. Well, Dr. DeBoos, thank you for your time, and I hope the audience found this information useful and helpful. Ladies and gentlemen, please stay tuned for another announcement or of another podcast from Miami Neuroscience Institute in the near future, and please follow us on the website, and thank you very much for your attention.
To find out more about the topics covered on the Doc to Doc podcast, please visit physicianresources.baptisthealth.net.